She is Honorary Professor at University Debrecen, Hungary. Her expertise lies in designing and execution of end-to-end research project of Ayurveda formulation. Ma'am has been the principal investigator of DST project, AYUSH project, and member of AYUSH International Cooperation Committee. She has delivered about 125 lectures as a resource person in several interdisciplinary workshops and conferences on public platforms. Ma'am has guided 15 MD students and 2 PhD students, published over 45 research papers, articles, chapters, and also authored books on research methodology. Ma'am is a reviewer of some intended journals like Elsevier, Scopus, and PubMed databases. She was the Ayurvedic expert for development of WHO benchmark documents on Panchakarma, Ayurveda practice and training. Ma'am is also practicing physician of integration lifestyle management for cancer, respiratory diseases, and PCOD.
At the beginning, I would like to thank the Nanal Research Foundation, especially Ashutosh and Esha, for inviting me here today and giving a chance to present something which is very relevant, not only for today, but for coming 10 years. And that is what is research in clinic. Now, for past 2 days, I'm here with you and I'm listening to the great stalwarts. So, respected Tapan Kumar ji and all other dignitaries who are present here, Mr. Ranjit Puranik of Dhoot Papeshwar, Prasad sir and everybody and all the dear students. I would like to take you from the Samhitas to the world stage. So I assume that your base of Samhitas is perfect. Like he said right now that no one is perfect, but yes, up to a certain limit, we do put in our hard work and we do know something and we have to trust in ourselves. So in that sense, yes, we know our science well, we are practicing well, and I learned this from 2 gurus. I started my Ayurveda education with Vaidya Kolhatkar sir, and then I continued it after he passed away with Vaidya Vilas Nanal sir. And meanwhile, teaching in Ayurvedic college, I got the opportunity to learn from many of my students, practitioners, academicians. So all that is I'm trying to put before you today. This is what is a Vaidya facing the world. A Vaidya has scientific principles. He knows what to practice. He knows applications. He also has to take care of the commerce involved. And if we are practicing within these 7 countries, India, Nepal, Tibet, Sri Lanka, Bangladesh, Mauritius, UAE, then we can write everything and anything. Right from Malla Sindoor to simple Tulsi or Ashwagandha, we can write left and right. We see the patient, we advise Panchakarma. We can use all these newly developed packets of Basti. So that's fine. But you know, in the country, in the world, there are 193 countries. And we are dealing or we are working only in these 7. What about that remaining 186? For that, we need to take a bird's eye view of what the world wants. And since there are many students here who are aspiring, who want to work in Ayurveda, with Ayurveda, for Ayurveda in the future, I think this understanding is very important. Taking yourself out from your cocoon and look at yourself from a different perspective. So how WHO looks at us? This is the WHO Traditional Medicine Strategy 2014-2023. So there are 3 definitions. One is traditional medicine. They have summed it up and they have given respect to all of us, that it is a sum total of practices, skills, belief, everything together, and which is used for treatment of physical, mental illnesses, and it's tradition of that country. Then comes complementary medicine. What is the difference between the two? Complementary medicine or alternative medicine refers to the set of healthcare practices that are not part of that country's own tradition. That means for us Ayurveda or Siddha is our tradition, and if chiropractic practices come to us, that is a complementary medicine for us. So these traditional complementary medicines are now, we are going one step ahead. In 2019, WHO has in their declaration refined or added one more aspect, that is integrative medicine. It is a combination of therapies and lifestyle changes to treat and heal. So integrative medicine uses evidence-based approach. Everyone here knows this term, evidence-based, to treat the whole person. So we are talking about holistic. Ayurveda's approach is whole person, whole system, holistic approach that has been acknowledged very well by the WHO, and WHO means its member states. So there are total 119 member states or even more. So all these member states, their representatives have come together and agreed and accepted that yes, traditional, complementary and integrative medicine is a part of mainstream medicine. Why this is so? Because all 193 medicines, only one medicine works at par everywhere, and that is modern medicine. I don't even say it's allopathic, it's modern medicine. So when we say that they are used to achieve optimal health. Yesterday, Mr. Shailesh Naik told us that there are changes in the country's progress indicators, which is seen here in this chart, that the number of member states with policy for traditional medicine, that means in these member states there was no policy for traditional medicine, and the number of member states creating policy for their traditional medicine has increased from 1999 to 2012 and today that has gone up to 69. Now the number of member states regulating herbal medicine, this is another area. Apart from traditional medicine, all over the world people are working with herbal medicine using the tenets of modern medicine. So all the aspects of pharmacology, toxicology, therapeutics, everything is put together. The lead is taken from the traditional medicine or even from the folklore or tribal medicine, and then you bring that medicine as a drug in the market. So for that also policy is needed, and 199 countries have adopted that as on today. So I think this information will take you 10 years in your future, that where we need to work upon, and we need a solid, meaningful impact of what we are doing today. So we have to understand that if we want to make Ayurveda a global medicine, or if we want to make its impact as a system of medicine, then definitely these factors we need to understand. There is a law of that country. You just cannot go and practice whatever you want to. There is Health and Family Welfare Ministry who takes care of the regulations. Then there is Education Ministry who is equally interested in regulating the education, what their students should learn and what not. It's same everywhere, it's for us also. Education system, we need to have some equivalence in level of skills and competencies. Many of my colleagues and now many of my students are residing in different countries. A few of them have even traveled to Chile. So US, Australia, Europe, many countries, then some Latin American countries and African countries, a few. So all of them face this problem, that how to get that equivalence. And therefore, whenever you are building up your career in Ayurveda, I remember I miss Nanal sir in this, that he always used to say, we don't only need Vaidyas, we need people everywhere. We need people in administration, we need people in policy making, we need people who are Ayurveda based practitioners or who are students of Ayurveda who can go into law ministry. And that's how we can build up a network which is suitable to take our science to the world. So there are medicine manufacture if you want to do. There are again the laws and regulations of that country. Imports and export policy of India is part of all these treatises, that is GATT, TRIPS, we are a member of WTO. So coming to Ayurveda and learning basic Samhitas is mandatory. I mean, based on that there is no option. You cannot put anything to option when it comes to the knowledge and science. But beyond that, we should be learning all these things also. So, what is the goal? We have to reach to these 186 countries as a system of medicine. Is there a way? If we want to take our medicines there, and people are trying it, people are practicing for last 30-35 years out there under different names, using different modalities, and many of them are successful. So how? By convincing that you deliver, and what you deliver is replicable, and what you deliver is measurable. So how will they get convinced? I'm telling you, we all are listening here, we are seeing cases. Vaidya Upendra Dikshit presented wonderful cases yesterday. So we know that yes, it's there, but how to convert that into evidence and how to convert that evidence into the pool of data? That's where is the question. Another issue which I always get from my practitioner friends and students is that, ma'am, there are lots of patients. If you are treating 40-45 OPD in a day, where is the time to keep the record and put the cases and generate the data? Absolutely right. I don't deny, because that's our roji roti, it's bread and butter. So you just cannot put your time into, doing research for all your 40 patients. So that's not the case. But you have to follow, you have to select the typical cases which come to you. There are two groups in this. You are prescribing Arogya Vardhini, you are prescribing Suvarna Kalpas. Select certain cases, and then there is a method to report those cases in a span of 2 years, where you can follow up the patient. You have to just take data of those patients whom you are prescribing a particular set of drugs. Or you are treating a condition, like you have seen the case reports yesterday. So that condition you are treating, and you are using multiple drugs for that. It also can be recorded methodically and presented as evidence. I want to draw your attention to this. Evidences are of two types. One is experiential evidence and other one is experimental evidence. Vayoho ratri bhuktanam tentam adhyadiga kramat. Remember? Sutrasthan, first chapter, right? Doshas, their time of day, night and age. Their kal, which dosh will be aggravated in the normal sense, which dosha's effects will be seen in that particular time span, lifespan, both. Now, in 2017, the Nobel Prize for Physiology and Medicine was given to a group of 3 scientists who developed or who could decipher the circadian rhythm using molecular mechanism, and which befits us perfectly. So again, Wele madam speaking here is cliche, because I am saying that what you are talking, this is already there in Ayurveda. If we don't want this to happen, or take the other example which I have quoted here, it is discovery of receptors of temperature and touch senses using nothing else but chili, kattuka. So, and the 2 scientists are here. They have shown experimentally that the cold and heat receptors are there in the body and they respond to different substances in a different way, and that has been used to understand the mechanism of many drugs and receptor channels. They received this Nobel Prize, and we are still here stating that we know Shadrasas, we know how they function, where they are to be used. So can some of us be the first one to talk about some basic principle and give its proof or evidence to the world And why not to think of Nobel? So the new generation, you must think of these things, and that's what is called evidence-based medicine. Another way of looking at things. I know Triphala. In my clinic, I use Triphala in multiple ways. It's here. It is an intelligent formulation. A group from scientists of Pune University, they have come up with this network pharmacology aspect of this particular simple everyday use formulation, and they have taken different anupanas. So it is with honey, it is with it is kashaya form, it is with ghrita and whatnot. So what is it that this diagram says? Here the green in the center, you are seeing those that brown, it is Triphala altogether. The green arrows are Amalaki, Bibhitaki and Haritaki. Then the bright green, fluorescent green spots are talking about bioactives. Now these are obviously the biochemicals, bioactives which are biologically active inside the body. They are 40 in number. They target 60 receptors. Those are shown in blue, those square blues. So these 40 bioactives target 60 receptors. And then they all could be linked with 130 disease conditions, and these 130 disease conditions can be grouped with the yellow spots. So orange triangles are disease conditions which are 130, and in the center of those disease conditions are the yellow spots which are talking about 24 types of diseases. This slide was presented by Dr. Bhushan Patwardhan when he spoke at some of the orations. This work was done by his group. For me, when I first heard it 5-6 years ago, for me the take home was my confidence in prescribe my Triphala my way increases. One thing, being a practitioner in India, but at the same time, when I have to talk to a person who is non-Ayurvedic across the table, this information, this research gives me added confidence. So while doing research, these are the methods: descriptive methods, case studies, case reports, epidemiological methods, laboratory methods. The one which I showed you is laboratory method. There are preclinical methods where particular activity is tested using some animal in a particular span. Then there are robust clinical trials, which could be of, big in size, big in numbers, big in budget, everything. And there are mixed methods as per the need of the objective. I'm talking this because yesterday I was one of the juries in all the presentations, and I could see that there is a lot more interest in doing research, even at PhD level and MD level, but students are struggling with the methods and the objectives. So I think this is a brief of that, and I am going to take you to how to select a problem, which design, whether my design is statistically sound. Again, I bring you back to the clinic. I'm sitting in the clinic, which design I should select? Can I do that robust fat budget clinical trial? No. If I do the trial on a small number, will it be statistically sound? Will it be impact creating? Who can I share the idea or ask for funds? Because I will be needing some funds doing this. As far as my experience in research for last 25-30 years goes, I feel that collaboration is the only solution. We have to collaborate, the clinician should collaborate with the person who is his friend. Go to, in the academia, go to the friend, approach him, share your idea, look for what you can do together with a small number of sets. So clinicians, OPD becomes a small research center. Then there are industries like Dudh Papeshwar, who have supported us for, if I have to tell you my experience, anytime, anywhere I have approached the Dudh Papeshwar and I have never heard a no. It's always a yes. Madam, you do, we are with you. So you can approach any industry in your area. you can convince them, you plead with them, and you have to join your hands with academicians. It's always, in one go you might not get the positive answer, but 2-3 times you get the real answer. Most of the time, 70% of the times the answer is yes, if you are sound and if you are true to your work and to your objectives. So you can work. How you can work? Basically, this type of research can go into case reports and case series. A few case series and case reports were presented yesterday, and Dr. Prasad sir has suggested some modifications in the presentations and other things. I was also asking some of the questions, and here it is how to present a case report or a case series. Case report is conducted on rare health condition. When I was in Hungary, a couple approached me with their son who was 17 years old and who has lost almost all his body hair. He was already bald at the age of 17 and his body hair were falling off in patches. Now I was in Hungary, I did not have my the standard kit of Rasaushadhis. Panchakarma was also restriction. On top of that, I was a ministry person. I was there deputed by the ministry as a chair. So if something goes wrong in that hospital, in the university, it was a tricky situation. What I did, I just went back to the Granthas. I said that this is Avarod and there is lot of Malasanga. So we have to go ahead with Shodhan. I cannot go ahead with Panchakarma Shodhan procedures. So I just simply started with Kumari in Uttam Matra. It was a huge dose of Kumari. Along with that, I could just use 2 things, that was Haridra and cinnamon, which was available. And in 15 days, the boy started showing hair growth on his scalp. After 2 months, there was those patches on his skin were regressed. But that boy definitely needed Shodhan Chikitsa. So I tried to connect him in India, in the centers, and then further the process went on. But this happens. Day before yesterday, so this is a rare case, rare condition. And I should present this case following this care format for case reporting. So you can present a case report using one case or a similar kind of treatment given to maximum 15 patients. Another term which I want to introduce to the students is meta-analysis. So if I present one case of this type, somebody else sitting in some other corner of the world writes about it, the third person writes about it, then there are number of cases. You put together the data and look for how the effect has come. Don't look for drugs alone. Look for the thought process. And there we can say that this is the proof of concept, what Samhitas are telling, and that we can show. We are giving evidence, we are creating evidence. So meta-analysis, pooling of data in case reports is also possible. Then there is case series, similar kind of studies, but the number of patients increases here, and this is possible to every clinician. So our purpose here is to introduce convincing evidence that could be replicable. I told you that presenting these case reports, there is a guideline. The guideline is called CARE Guideline 2013, and this guideline is available on our ministry's website as well as CCRS website. See how explicitly everything is mentioned in that guideline. The title, diagnosis or intervention of primary focus, followed by the words case report, right? Keywords, 2 to 5 keywords should be there. What is the importance of keywords? Because of the keywords or using the keywords, a paper is categorized or coded in the database. So people world over, when they are searching for some answers, if you type balding or if you type khalitya, palitya, I mean the equivalents from the modern medicine, then definitely your paper is visible, and that's why selection of keywords is very important. So Ayurveda, traditional medicine, We always use that. But apart from that, you have to understand the mesh terms and code the paper using the mesh terms so that its visibility increases. And by that, we reach to the needy person who really wants to know something for some condition which is not there for him. Then the abstract. It has to be a structured or unstructured depending on the journal style. Introduction, then the patient's main concerns, primary diagnosis, intervention and outcomes, conclusions. So this is a very standard pattern and you should not deviate from it. Yesterday I could sense that many of the presentations followed this style. This is the style for any case presentation. I mean, not only case presentation, any of the research work, you have to follow this style. Especially for case report, we have to give importance to that patient information. And just before that, we have to summarize that why this case is so unique. Now, if you ask me, we are treating Grudrasi patients in and out. We are treating Kamala patients in and out. We are treating Amla Pitta patients in and out. Then what is so special about, submitting or presenting a case report on Amla Pitta or Grudrasi or Kamala? No point. But if you find that one Amla Pitta patient, you have treated him for 2-3 years and still nothing is happening. So look for something where there is no answer. And there you have a chance to work better, to heal the patient and then present the case, and that should come into the introduction. Then in patient information, de-identification of the patient's identity, you have to write about the primary concerns and the symptoms, then medical, family, psychological history, social history of that patient, relevant past interventions and their outcomes, that you have to mention. Otherwise, what you are doing, how it is different than others will not be evident. Clinical findings, you have to describe with significant physical and important lab reports also. You have to give the historical and current information about the timeline as well as the episode of care organized at that particular time point. I'm going to show you an example of this. Then diagnostic methods. So each of the point in this guideline is very precise and you have to address each of these points when you are writing a case report. What was your therapeutic intervention? How do you administer that intervention? Whether it was a Bahya Chikitsa, Abhyantar Chikitsa, you gave it using the kalas like Saman Kal, Vyanodan Kal, Rasayan Kal, Apan Kal, whatever you have done. And the changes in the therapeutic intervention which you have done, you may have done for this particular case because it is a rare case, you must mention all that. Then the follow-ups and outcomes. If you have seen some adverse and unanticipated events, you don't want those events to happen, but you have to be nishpaksha and nirapeksha. So you have to sit in the middle. Whatever is happening, report as it happens. And then discuss the strengths and limitations in your approach to this case. So while doing this, discussion of relevant medical literature from the Samhitas as well as the latest published literature, you have to take the rationale for your result. You might have got good result. 2-3 days back, I heard a case presented by Dr. Girija, and in that case presentation, the person did not have, he was again a 7-8 year boy whose teeth never came out. There was no teeth. And then after 2 years of treatment, there were 8 or 10 teeth. So stick to that. That patient, he got his teeth back and something dramatic, something out of this world, that should never be written and presented. So we have to be rational in the conclusion. Extremely good results, dramatic results, excellent results. These are not the terms to be used here in the case presentation and case reports. We are talking on the scientific platform. So one primary takeaway from this particular case should be there. Where, apart from that, why this is called evidence-based medicine? In the Cochrane database, people have come up with the patient's perspectives. So especially for case reports and case series, while taking the treatment, what was the contribution of the patient? How he took that treatment? Some of the patients don't like the ghees, bastis or whatever we do. So in the beginning, it takes a lot to convince them. But afterwards, they get adjusted and they do complete the treatment. So all this experience of the patients in their own terms, that comes in a box that is published. So that is called as patient's perspective, and that takes our research reports to the level of evidence, and that can be included in the Cochrane database. Informed consent, you all know that its importance, and registration in the CTRI database is not there for case reports and case series, but it is there for all other study designs. I have also given a link here. This is a care checklist writing outline. It has been translated in many languages, but unfortunately not in any of the Indian languages I could find. International languages it is there. There are some modules which will train you how to write a particular point of this care guideline. So do try that. This much definitely a clinician can do in his practice. And if you do that, there are the journals who publish case reports. Well-written case reports have become a feature post-COVID. Journal of Ayurveda case reports, which is managed by All India Institute of Ayurveda, New Delhi, and Journal of Ayurveda and Integrative Medicine under the review of Transdisciplinary University, Bangalore. Both this first journal, All India Institute's journal, is dedicated to case reports because we want more and more data to show the evidence, and JIM has a section of case reports. So if you do good work, clinician can always publish here. Still, I know that publishing is not a very easy job. If I get some time, I'm going to touch upon that. Here is that example of case report. And I'm sorry, I generally don't write such slides, but today there was no option. There are definitions and something which I want to share as it is. So I have used this format. Children with cerebral palsy. This is a case report, Panchakarma therapy in cerebral palsy in a tertiary care hospital, a case report. Remember the first point, rationale for this particular case report. So children with CP have different type of physical disability which depends upon the extent of involvement of brain damage. Children are not able to perform activity or attain milestones on time as the other children of their age do. The symptoms appears diagnosed during the first 1 or 2 years of life. Muscle relaxant like baclofen are recommended for managing muscle spasticity in CP. However, long-term administration of these muscle relaxant is associated with abuse, potential, and many adverse events. That's why this case report discusses on the successful management with Ayurvedic intervention of a diagnosed case of cerebral palsy with satisfactory recovery. Very clear, understandable, easy, and giving a complete idea of why this case report is there. Then see the presenting concerns. 6-year-old girl child attended All India Institute of Ayurveda Tertiary Care Center with delaying in walking and spasticity in both the legs. Patient was born, past history during the delivery. The patient was born at 29 weeks preterm with LSCS having low birth weight, below 1.4 kg, and history of birth asphyxia. She was kept in nursery for 18 to 20 days after birth, and the features were suggestive of cerebral palsy. Intervention. The patient has undergone treatment from different hospitals, past history for this particular patient of treatments. So the patient has undergone treatment from different hospitals, also operated for knee contractures 2 years back but got no relief, not started walking. At this point, Ayurvedic Panchakarma procedures were started for 17 days. That is Udvarthana with Kolakulathadi Churna for initial 3 days, followed by Sarvanga Abhyanga with Kshirabala Taila and Nadi Sved with Dashamul Kvat for 14 days, along with Matra Basti of Kshirabala Taila 10 ml for 7 days. Such 2 courses were given with an interval of 2 months. The outcomes here are: patient responded well to the Ayurvedic Panchakarma procedure and started walking with support into bracket 2-3 steps at a time, and improvement in sleep pattern along with overall improvement. So main lesson from this case report is the condition of CP has no cure in any medical system. It can be compared with Vata Vyadhi, and therefore this case study demonstrates the need for further studies. This is how a case report can be presented. Similarly, for COVID, when we studied the CTRI, that is Clinical Trial Registry, I just want to bring to your notice that total 9,961 cases have been registered from the Ayurvedic fraternity, and this is the response which we want to create even more for COVID. So this has never happened before, and this gives us some confidence about variety of Ayurvedic treatments. After filtering this data, we could come to mainly these formulations: Guduchi, Ayush 64, Ashwagandha, Indukanta Kashai, Kalamegh, and then for post-COVID, Chavanprash. I am not here to tell you that, okay, post-COVID you use this drug. No. But when people have tasted, tried and created evidences, we could come up with some of the solutions. Yes, I was a part of this WHO benchmark for practice of Ayurveda, which is to be practiced world over. And here, I just want to leave you with some tips, tips for practicing as Ayur physicians, overcoming all the obstacles across the world. We have to follow the reporting guidelines, creating evidence so that we will be able to convince the world. We have to follow the guidelines on Namaste portal right now, because we have created an equivalent database which is equivalent with ICD, International Classification of Diseases, and thereby whatever we write, it is easily accessible again to people across the world. So that should be our part, and keep the track of policy for drugs, trade and practice. So being an Ayurvedic physician at the core, we want to also upgrade ourselves with this. I'm coming to my last slides. I'm just going to get through this. This is the Namaste portal where you can see the ICD guidelines. Here is the vision and mission of the portal, and it has made very user friendly. So while doing your research, especially for postgraduate and PhD students, if you use this and you start publishing, we will be generating huge amounts of data in the format that the world requires. It also, we convince world, but it also increases our confidence that, okay, this is what is accepted by everyone and we can do that. So these are some of the slides. You go to the portal and see for yourself. These are the hits, latest hits post-COVID. And I want to end with this slide. Ayurveda is beyond cultures and it offers health for all. It has the potential to become a part of the global medical community. So basic framework for the principles and methods to analyze geoclimatic conditions, human body makeup, seasonal variations, foods and medicines specific to that area, disease specifications, drug delivery systems, clinical approaches and scientific approach with experiential wisdom. We have all that. So it's time to create evidence using our wisdom and following the guidelines for taking our Ayurveda to the global stage. Thank you very much.